Good morning, everybody. The webinar will be starting shortly. Preparing communities for COVID-19 Session 7. Today, we're going to be talking about COVID testing. Please enjoy our pictures throughout our pre-webinar display and also join in our word cloud coming up shortly. So before we start today's webinar, our word cloud of the week is, what is the first name of some of your healthcare heroes? Text that into 22333, and then in the message line, put in COVID-19 heroes, and you can put in as many first names as you want. The webinar will be starting shortly. Preparing communities for COVID-19, Session 7, COVID testing. The webinar will be starting in just one moment. As we wait for the webinar to start, please join us in our word cloud. Get out your cell phones and text 22333 and put in COVID-19 heroes in the message line. And then you can put in, what is the first name of some of your healthcare heroes? You can nominate more than one. Please join us. The webinar will be starting shortly. The webinar will be starting shortly. But before that, we want to say we are forever grateful for our community healthcare heroes. Thank you to all you do within the healthcare setting. Please join us for our word cloud. What is the first name of some of your healthcare heroes? Please type in 22333 and put in COVID-19 heroes to join us in our interactive word cloud for the day. What is the first name of some of your healthcare heroes? You can nominate more than one. The webinar will be starting shortly, Preparing Communities for COVID-19, Session 7. We're talking about COVID testing today. Please join us. We'll be starting shortly. But first, we want to make sure that everyone knows we are forever grateful for our community healthcare heroes.
Hello.
Before we start the webinar, we want to make sure that you're joining in our interactive word cloud. Type in 22333 and put in COVID-19 heroes. And then you can answer the question, what is the first name of some of your healthcare heroes? Please join us. The webinar will be starting just in a minute. The webinar is going to be starting shortly. Today's webinar is on Preparing Communities for COVID-19, Session 7. Today, we're going to be talking about COVID testing. So good morning, everybody. We're going to start today's webinar. Thank you for joining us on our weekly webinar series, Preparing Communities for COVID-19. And today we're going to be talking about COVID testing. But first, before we start the programming, we want to make sure that you're joining in our interactive, real-time word cloud. Take out your cell phones, type in 22333 in the to line, and then put in the message line COVID-19 heroes. And then let us know what is the first name of some of your healthcare heroes. You can put in more than one name. Throughout today's webinar, we'll be watching this word cloud grow. And at the end of the webinar, we'll be taking a look at this word cloud again of our healthcare heroes. So now let's go ahead and start today's webinar. So thank you for joining Preparing Communities for COVID-19. This is our 7th session, and today we have a very packed agenda. First, we're going to hear from our CEOs of both Alliance Chicago and also Health Choice Network. Alliance Chicago, and Health Choice Network are co-sponsoring these weekly webinar series on COVID-19. Then we're going to hear directly from our health centers. We'll be hearing from 3 health centers who are at the forefront of COVID-19 testing, and they will share with us their experiences. And then we're going to hear from a national perspective from our colleague, Dr. J, who's going to tell us about what should we know as clinicians and healthcare providers about the testing methods. Then we'll also hear from our partners at the National Association of Community Health Centers on a national perspective on COVID-19 testing. And also, we want to hear from our public health department, and we'll be hearing specifically about COVID-19 testing with a public health perspective. And then we'll wrap up. So first, let's start off the webinar with our colleague, Dr. Fred Rockman, the CEO of Alliance Chicago. Fred, are you with us today?
I am, Tim. Can you hear me?
Perfectly.
Great. Well, welcome all. Again, exciting to be on this call and hear from all of you. As we're beginning to see some encouraging trends in the statistics around COVID, naturally there's momentum building in conversations around returning gradually to normal business. And planful approaches in this are going to really obviously depend on more comprehensive testing strategies, especially to monitor the impact in states that are more aggressively moving forward, but also to make sure that we've got proactive infrastructure in place for those states that are still to begin to implement some rollback of social distancing. We also need to have better tracking mechanisms to better understand the natural course of the disease, because there's still very concerning gaps in our understanding of what that natural course is. For example, what susceptibility is to people that have already had the disease and are developing antibodies, what the role of antibody testing will be, and what late impacts will have. Health centers really have a critical role in these testing strategies. We need to be assuring that there's inclusion of the vulnerable populations in the strategies, that we really are understanding the influences of other factors that we know to be important: race, ethnicity, income, access to care, and underlying conditions, as well as social determinants. So we're all eager to learn today from you about what your experience has been to date, so that we can really understand even better how to step up as a virtual healthcare system nationally and contribute to these efforts. So Tim, excited to hear what folks have to share.
Great. Thank you, Fred, for those words. We appreciate it. Next, let's hear from our other co-sponsor, CEO Alex Ramil from Health Choice Network. Alex, how are you today? And Alex, we're going to give it a moment here. I think we might have you on mute. So Alex, let's hold off. Yes, there we go, Alex. I knew you were coming through. Please,
that's
take
my
it away,
staff.
Alex.
They put me on mute on purpose. That's my staff. So good morning, everyone. Thank you once again for joining us. We're so excited to see this webinar series continue to grow. Some of the speakers today are part of my healthcare heroes that have not only taken the charge, but are the only testing opportunity in some of their states. So thank you for sharing your stories with us. I just want to say on behalf of Health Choice Network and our board of directors, we're so excited that we can continue sharing best practices. Looking forward to you guys sharing your stories, your challenges, your opportunities, and as Dr. Rockman mentioned, what are the opportunities and lessons learned we can take forward as we try to return to this new normal. I can tell you at Health Choice Network, we're doing things that we never thought before. We're driving forklifts. My entire office right now looks like a warehouse. We're trying to get our health center members and all health centers abroad the supply that's so desperately needed. As I work with the National Guard here in South Florida and our hospital information system partners, I can tell you that when you hear about testing, they're all very concerned outside of the press releases on how many of these testings are actually effective. We've actually, unfortunately, received a lot of tests from the stockpile that we can't use. So to once again see our health centers take the charge, be at the front lines of this pandemic and serve their communities is no surprise to me. So I look forward to hearing from the speakers. I also would like to encourage you to share the webinar series with all your colleagues. This is not specific to any membership with any of your HCCNs or PCAs. We do want to open it up. We want to hear about great speakers and great content out there. So please keep that information flowing. That's how these webinars continue to be effective. And number two is we do have an upcoming webinar series next week, which we're going to focus on what the PCAs, HCCNs, Department of Health, NAC, FAC, all the supporting organizations behind the scenes of health centers are doing to prepare for the new normal and also to make sure we have the right tools in play to continue our national efforts. Health centers have always left the charge as far as quality goes. So as we look at this pandemic and it's taken a lot of our focus, we can't lose focus on the pre-existing conditions in our patients that need assistance outside of COVID-19. So we're excited about sharing some of the best practices, some of the infrastructure. I know Health Choice Network Board of Directors and the Alliance Chicago Board of Directors are making initiative investments and to make sure our health centers are prepared for this future. So with that, thank you again. You are my heroes. I appreciate the work you're doing. Keep sharing your social media posts. We love to repost those. And take it away, Tim.
Thank you, Alex. Appreciate those words and also appreciate the plug for next week's webinar. As Alex mentioned, we will be focusing on the HCCN, PCAs, and also this is not just for membership of Alliance Chicago and Health Choice Network. We have over 550 registrants for today's webinar. This is for anyone who wants to come together, share stories, learn the good and the bad about the experiences that we're going through with COVID-19 now. And so with that, let's dive into our programming. First, we're going to have a polling question, so get out your phone. And the polling question number one is, how is initial diagnostic COVID testing collected at your health center? And I think if we go to the next slide, it will have, how is initial diagnostic COVID testing collected at your health center? Number one is on-site by healthcare provider. Number two is home self-collection. And number three is on-site self-collection supervised by a healthcare professional. So in the essence of time, let's quickly look at some of these results. And we will be able to see now in real time, the majority of the diagnostic COVID testing collected at your health center is done on-site by a healthcare professional. I think in the future, that may change, but we want to make sure that we have these statistics now, and we'll take a look at it in the coming weeks. So let's move into our first health center. Legacy Community Health Center is in Houston, Texas, and Dr. Wen is the Chief Medical Officer of Legacy. Dr. Wen, are you with us today? Let's give it just a moment to get Doctor's audio going there.
Dr. Wen, your line is unmuted. Please make sure that on your end you have also unmuted your line.
Now?
Yes, we can hear you now.
I had
Your
to switch.
presentation and slides are up.
Okay, sorry about that. I switched to the computer, so please I hung up on the phone, so maybe that was the issue. But you can hear me fine right now, is that correct?
We can hear you perfectly.
Okay, perfect. All right, well, thank you so much for having me. I just wanted to spend a little bit of time sharing what we've been doing here in Houston at Legacy. If you could go to the first slide. It seems so long ago, but really it was just in March that we pulled our resources together to offer testing in about mid-March. And at that time in Houston, our city and our county were still trying to get everything together. It was tough due to a lot of just changing information, but also lack of supplies. But we were able to proceed with opening the first 3 testing sites in Houston at our largest clinics. We have about 15 clinics, but they all range in size. And so we were able to regionalize the testing to cover most of Houston with our 3 tents. And for those first few weeks, we were the only ones testing in the city. And so you can imagine that it was very crowded, and at that time, the testing criteria was pretty tight. We were only testing patients who had self-reported travel or exposure with symptoms. And so we tested about 1,500 patients during those first few weeks. And once the city and county were able to open up and offer other testing sites, we took down the tents but continued to offer testing sites at 14 of our clinic sites. Next slide, please. We worked pre-COVID. Our third-party lab was LabCorp, and so we started testing with their confirmatory test swab, which is the nasopharyngeal swab. And interestingly, we are actually moving towards the self-swab starting next week, and that's really to help operationalize the scheduling, and we're going to do drive-up testing. And so in conjunction with our telemedicine visits, and that's really what drove us to look at self-swabs. And so the model that we're going to be moving towards is if patients call in with respiratory symptoms, we're going to continue to offer a telemedicine visit first. And if during that visit, it's assessed that the patient needs a COVID swab, then we will schedule them to drive up and do the self-swab at our site. If a patient cannot do a telemedicine visit, which our patient population, some don't have the tools and internet needed, then we will see them in the car and offer a car visit and then do the self-swab that way. And there's been a lot of talk about antibody screening, and at this time we decided not to move forward with the antibody screening, mostly because, well, twofold, I guess. A lot of the antibody screening tests there are a lot out there, but not a lot have been officially FDA approved. And then there's still a lot of question about the false negative rate. And then the cost is the other. It's double the cost right now of the swabs that we're using. In terms of criteria, I'm sure everyone on this call has experienced the ever-changing guidelines has caused not only a lot of stress for our providers, but certainly for our patients, the community. It's very challenging already to communicate and educate our patient population. And so this added changing guidelines has been very stressful for the patients. And so, like I mentioned, originally we stuck with patients having to have symptoms plus a travel history or an exposure history. And then we moved to dropping the travel and exposure once it got to a community spread. We didn't use that criteria anymore, and we just focused on patient symptoms, but if they were high risk. And so if they were in the elderly population, if they had comorbidities such as underlying respiratory disease, or if they were a healthcare worker. And so that's actually the current guidelines that we're using, though we know that recent changes in April include asymptomatic testing as well, which is now what our city is offering in most of the country. But that we were balancing that with our supplies. And so since that was a criteria 4 in the CDC, we chose not to adopt that. We only are testing asymptomatic employees that have an exposure to a positive patient encounter or a positive colleague. And just I added in there, there's been a lot of requests to us from other businesses about return to work testing. And at this time, we, for the same reasons of not testing asymptomatic patients, we are just trying to balance our supplies to ensure that we have enough to offer it to patients who we have deemed as are higher risk, and then our own employees as well. Lastly, this is just a slide of from when we first started testing till now, what our numbers look like. Really, the last line is probably the most. I probably should have deleted the first 3 rows because it's not really pertinent. But ultimately, at this point, we've tested about 2,200, close to 2,300 patients. The turnaround time has improved drastically. When we first started, I didn't mention, but it creeped from 7 days up to 14 days for most of the month of March. And once we got to mid-April, we started to see the turnaround time go down to about 3 days. And that was due to LabCorp adding additional processing facilities across the country. And so that really helped our turnaround time. And we've been pretty stable in our positive percentage. It's ranged between 10 to 15% pretty much the whole time that we've been testing. And right now it sits a little bit less than 15%. And that is all the information that I brought. I don't know if there are any questions in the chat area, but if time allows, I'm happy to answer anything or also move on. So just let me know, Tim.
Great. Thank you so much for letting us know what the experience that Legacy is going through in Houston. We appreciate all of these patients that you have tested. It's a very, it's a great number, and we appreciate it. If people want to ask questions, please type that into the chat. If we don't get it live to the speaker on the webinar, we will be collecting all of the questions placed in the chat, getting the answers from the speakers, and then disseminating those answers out to everyone who is on today's webinar. So thank you. So as we move forward to our polling question number 2, we'll be doing this on the GoToWebinar, so on your screen, so not on your phone. Sorry about that. Polling question number 2 is, which additional COVID testing does your health center collect? So are you doing antibody testing, antigen testing, antibody testing, both, or only initial diagnostic testing? I think if we move to the next slide, you'll be able to answer the question. Which additional COVID testing does your health center collect? Antigen, antibody, both, only initial diagnostic testing. We'll give that just a moment, and just as to get a quick snapshot of people who are responding to today's poll question number 2. And here we go with some of the results. It looks like most people are doing this initial diagnostic testing. Some are doing both, and some are doing antibody testing. So most are doing the diagnostic testing. So thank you for that poll question number 2. And next, let's move to our colleagues up in Providence, Rhode Island at Providence Community Health Centers. So Dr. Andy Saul, Chief Medical Officer, is with us. Andy, how are you today? Clearly, we're having some audio opportunities today. So we'll wait one moment for Dr. Saul to join us. I think he's on the phone and maybe muted on the phone.
There we go.
There we go.
How's that?
Yes. That is great, Andy.
Technology.
Great to hear your voice again.
I know. Me and technology, we go way back. Happy Nurses Day to everybody. We know who really runs the world, and it's not us. Greetings to everybody across the country, and the usual things. Though I may be conflicted, I have no financial conflicts of interest, and I'm thoroughly unelectable, so I'll try to stay within the guardrails of being nice today. Next slide, please. Greetings from Providence. We are conveniently close to New York City. We live in the shadow of the great city, and we're also right between Boston, and this makes things very interesting when you add high-speed rail and a very, very fluid population. It's been a really long couple of months. Next slide. We are blessed with an extraordinary director of our health department. That's Nicole Alexander Scott on the right. And we have a wonderful blue dog governor on the left. She's pro-business, but she gets it and she listens. This was an article in the Washington Post a couple weeks ago about state policies. Next slide. And, of course, the New York Times. Rhode Island's been doing really, really neat things. Next slide, please. Pushing the boundaries on who can be tested. A little bit about Rhode Island. Almost 20% of the state does get primary care in an FQHC. We did expand Medicaid. We have a single health information exchange. I think that's why Tim asked me to speak to you today. I'll show you what we've done with that. And we have one health department that covers the entire state. Next slide. We started planning with the Guard back in January, and our state National Guard stood up in February. The whole point of this was to buy time for the private sector and the FQHCs to develop their own testing capacity. So Rhode Island came out of the gate with 3 very large public test sites that could do almost 1,000 a day. And later on, CVS, a grand and glorious corporate partner of the state of Rhode Island, came forward and began doing rapid testing at one of the casinos here, and that brought another 1,000 tests a day online. Next slide. There it is. And in the words of the fat man from the house of God, you can't find a fever if you don't check a temperature. So we are doing lots and lots of screening in our very, very diverse population. Next slide. A little bit about this health center now. 60,000 patients, 8 neighborhood clinics, 17 languages. 70% of our patients self-identify as Latino or Hispanic. 9 out of 10 would be eligible for the sliding scale if they can't get on Medicaid. And insert your favorite Rhode Island joke here. We are indeed responsible for 10% of all the deliveries in pediatrics in the state. And right here in the city of Providence, 70% of the kids in the school district get their medical care in our clinics. Next slide. There we are. And one more slide. Next slide, please. So I challenge you here when you look at this great testing strategy, tell me what's wrong. Is it A, many refugees from around the world where there's been a civil war don't respond well to military uniforms? B, undocumented patients may have trust issues with law enforcement. C, we're assuming everybody speaks English. D, assuming that only those with cars can access car-based testing. E, wondering who's paying. Or F, all of the above. Next slide. And our experience, of course, is all of the above. We've got patients from Cambodia who absolutely refuse to go near anybody with a military uniform. We get it. And when you look at transportation, if you set your system up to only accommodate people in cars, you will only test people with cars. And as we know from our social determinant screening, we've got some significant people who cannot access public transportation or have a vehicle. Next slide. So we did something rather fun along the lines with our cousins in New York City. We set up a walk-in test site. And this is to better serve the population who is on foot. And this surreal photo ran in the Washington Post last week. Still chills me to look at that thing. Next slide. Here's kind of an overview. The red line shows a vehicle moving through a 2-tent system, but the orange line down at the bottom left shows the walk-through capability. And it's phenomenal. People are able to walk. We've got about 10,000 people near one of the largest sites and numerous people coming on foot. We're also finding that many people, since they can't get in to the fixed schedule vehicle site, will park nearby and then walk to the test site. Didn't see that one coming. But we want to thank the National Guard for helping us set this up. Next slide. Currently, we are following the CDC guidance. We threw travel screening out the window very early on because the prevalence went through the roof quickly. So if you are an adult, we're basically screening pretty much anything on this list, 2 or more. Next slide. In pediatrics, we've got a bunch of pediatric ID people affiliated with Brown, a pediatric hospital, and people yelling in my ear all the time, and they're the ones who filled us in on the blanks. Yes, children are indeed different. Yes, they don't necessarily present or get as sick, but the poor AAP is caught on a political crossfire. And so what you're starting to see is that areas around the country where they do have good access to testing, the pediatricians are starting to test more. And please pay attention to news coming out of New York. We anecdotally are beginning to see a Kawasaki-like post-viral illness in our children. So that may be a good reason to test kids. On the OB side, our local hospitals are now doing universal screening. And as I discovered at 2 in the morning, the nurse took the baby away from the COVID positive mom and called Child Protective Services. By 6 a.m., we had the CMO of the hospital on the phone, and we realized, you know what? We really need a policy. And our other big challenge right now is, now that mom's COVID positive in the first trimester, what's our plan to bring her in for ongoing prenatal care in trimesters 2 and 3? So those are kind of the big issues at hand. We also have a special population. We have a homeless healthcare tower, assisted living, and in this tower there's 200 residents. There is 1 bathroom and 1 rec room on each floor. This is a setup for a big problem. So we're doing a congregate strategy testing. It's similar to a nursing home. Everybody's being tested. It's voluntary but incentivized with a Dunkin' Donuts gift card. We're screening the symptomatic as well as the asymptomatic, including the staff, and it's tied in with the health department to move people to a hotel if they happen to need quarantine. And we're going to keep doing this every 2 weeks for the duration. Next slide. We have been experienced with the Rabbit Apid test. That didn't come out right. Rabbit Apid test. I like that. The Abbott Rapid Test results in 13 minutes. Sensitivity relies heavily on the technique. And if you are counting on patients to do self-swabbing, they won't go deep enough and your sensitivity goes down. Next slide. We did have access to one of these, but the state could only come up with 72 test cartridges. So instead, we changed strategy. Next slide. And we are all in on PCR-based RNA testing. And we're doing our own testing and sending these to multiple labs. And we've got the turnaround time down to about 1 to 3 days. The gentleman on the left is a podiatrist. So earlier when we asked the question about who's doing your testing, our healthcare workers in the tent, we try and aim for podiatry, optometry, dentists, and those lines of business that we are currently scaling back at the moment. Let me tell you, that podiatrist is really good at getting a swab in the nose. Next slide. Antibody testing. I want to defer to Dr. J, who's coming on in a little bit. If you catch any inkling of me being against this, it's because we're talking about the point of care antibody tests. I think Jay is going to be talking about serology, which is a different bird. Please pay close attention to these. What they marketed in Europe under emergency use has very suspicious sensitivity and specificity. No one's got any real good data yet. Can we use antibodies to diagnose an acute infection? Maybe. Can use it to prove immunity? Ask again in a year. The problem we're having right now is if you have to wait 8 days for the IgG to become positive to really know it, you've missed your window to intervene with your public health outreach. So rapid testing at the point of care is a very, very big topic. We need to be looking at this. But if we're going to have a public health intervention, we need a faster and faster methodology. Next slide. Some guidance from the Rhode Island Department of Health along those lines. Next slide. These will be available for download, by the way. Our standard site design we talked about briefly. You can see it on that other picture. We're talking about 14 people to pull this off and a total of 4 swabbers a day. If you do it well, you might get an upwards of 100 a day through your test site. That is very, very expensive and very deliberate, but we are doing it in the cities where no one else was testing. Next slide. We are doing it by appointment only. When you do walk up, remember that's not walk in and be ready for crowd control. Our big problem, of course, is testing outdoors. That really stinks. And we're beginning to look for a warehouse or some way to sustain our testing efforts through the summer and into next fall. We're not planning for this to go away here in the city. Next slide. And of course, while you're waiting, we double down on patient education. If it is 1 to 3 days, we want to make certain that everybody is conveying the message in every language possible. If you're sick enough to test, you're sick enough to stay home and continue to quarantine. You can see a nice little Skype message I got the other day from one of our docs. Next slide. When we do deliver results, we're doing phone-based. We've not necessarily used the nurses for this because there are many, many, many nuances in how you interpret it. We suspect we may have people who continue to shed RNA even though the viral infection is gone. We don't know what that represents, and we're talking to some other people about it. The big point here is that just because the test is negative, it's not a reason to go outside and break quarantine. And just because the test is positive and they think they're feeling well on day 5, it doesn't mean all is well. And please pay attention to your healthcare workers. You may need different rules. Next slide. Here in Rhode Island, we actually worked with our State Health Information Exchange to pull results in from several labs in several formats, and then we merged them all into one data bank. And that's where we got a lot of the data. We personally have done just under 1,000 tests, but we are aware of 4,200 of our patients having been tested in the hospitals, ERs, and out at the National Guard sites. Of those 4,200, 1,400 are positive. We're aware of at least 7 health center patient deaths and are 20 or more people currently in the hospital. Next slide. And as you begin to dig into that data, what we're realizing is that 34% of the people we're testing are positive. The state's composite rate's only 15%. So the joke, of course, is either our docs are really good at predicting who needs a test, not. That podiatrist with a nasal swab is really good at getting a biopsy of the pituitary gland, not. Or the prevalence of the virus is much, much higher in our service population, and that's indeed what we're looking at. So when we are able to sort by race and ethnicity, we start seeing a trend like this, and there's a 10-point bounce there. So if 70% of our service population self-identifies as Latino, but 80% of the results are there coming in positive, that's a problem, huge problem. Next slide. And so we're working with our state health department to develop better policy. Rhode Island overall, 16% Latino, but 43% of the positive tests are Latino. What does that 43% represent? Well, spoiler alert, it's not about genetics and it's not about ethnicity, because we're able to crosswalk our data and go really, really deep on the social determinants. It is indeed about the jobs. If you can't work remotely, you're more likely to get infected. It is indeed about the housing. If you live in a triple-decker apartment with multi-generational families, you can't socially distance. And it's about the financial resources. If you can't shop online or have it delivered, you got to go out to the supermarket. So that, of course, is why we're addressing the community health centers. We are the right people in the right place at the right time to address this and to make a difference. So thank you all for this opportunity to share some data with you.
Andy, thank you so much. You guys are doing such phenomenal work in Providence, and thanks for your leadership on this effort, both not only at the Health Center, but in the state. If there are questions for Dr. Saul, just put them into the chat. We'll see if we can collect them either in real time during today's webinar, or we'll be getting the answers to your questions later. So again, Andy, thank you very much for presenting your Health Center's experience on COVID-19 testing. So we move to the next slide. We're going to hear from another health center. And here we're going to hear from Found Care. And Dr. Marriott's going to tell us a little bit about the experience over the last several weeks at Found Care. We have heard initially in one of our webinars early on about some of the experience at Found Care. And now we'd like to hear a little follow-up. How's it going? So, Dr. Marriott, are you with us?
Can you hear me?
Yes, we can hear you well.
Perfect. Okay. I think it's a good thing that I'm following our colleagues there in Texas and Rhode Island, because pretty much that we kind of meld into that in terms of what the work we've been doing here at Found Care in South Florida. So if you can advance to the next slide. So we started our drive-up testing, seems like on the same day as our colleagues in Texas on March 16th. We had, and it was really just out of the bat, we started with some calls on the weekend. Our CEO, Yolette Bonet, gave us all senior staff a call. We were on the phone all weekend planning, and Monday morning we rolled it out. And we started with some strict criteria because, again, as our colleagues have mentioned, our resources were limited, our PPE was limited, and our supply chain for the testing was also limited. We pretty much raided our clinics and found what supplies we had and determined that, yes, we can go ahead and start, and we'll do it until we can't do it anymore. And as we've experienced over the last 8 weeks, the supplies have started to trickle in. So we started with appointments. We opened up an appointment line, and in that first that first few days of even the appointment line being open, we had thousands of calls already that came in. And so being the size that we are, which is we have 7 clinics of varying sizes as well too. But our main site, is able to accommodate not more than the 10,000 calls that we got. So we had to be very strict with the criteria and schedule people out. And in those initial days, we scheduled people out for weeks. And of course, people are like, well, I'm going to be dead before I get the test. But there was no one else in the county at that time who was doing it. So we were doing the best that we could. We started with the nasal pharyngeal and the oral pharyngeal swabs. And I'll tell you how we've advanced from since then, and PCR testing. And as mentioned previously, we were using primarily Quest, and it was taking a couple of weeks. And it was variable, though, because you would have some results that would come back in a few days and some that would come back even from the same day within a few weeks. So that was very frustrating for the patients, but for us as well, too. We started with a few days a week for the drive-up testing, and we also included a few Saturdays on there to accommodate the patients who couldn't come during the week. At that time, the state wasn't shut down yet, so people were still working, and so the Saturdays were a little bit more convenient. And in those first couple of weeks, we tested about a couple hundred patients each week during those time frames. Next slide. So in the following weeks 3 to 4, thankfully the cavalry arrived, and more testing sites within the county began to open. And as a result, in a good way, our numbers started to level off in terms of how many patients were coming through the drive up each session. We decided that we were going to honor our remaining appointments, as well as any non-scheduled patients that may have come in, patients of ours, staff, et cetera, that needed to be tested. We were honoring all of those, and with a plan at that time to maybe even stop testing as other sites, large sites, were opening in the county. So we also switched to using the nasal pharyngeal only swabs. I don't think the people who were coming up were really liking that. They were expecting the oral pharyngeal swabs, but we found better reliability with the nasal pharyngeal swabs. And at that time, too, as the lab saw that we were doing more and more of the testing, it seemed like they were having let's say a bidding war necessarily, but they were looking for the business. And so the supplies started to come in faster, and the turnaround times also were improving. We were also getting PPE supplies that had begun to come in from various sources, people donating, other clinics donating to us as well. So in week 5, received several calls from local partners to facilitate testing in some of our underserved areas. As we had watched the news and as we evolving, we're realizing that a lot of our patient population, as well as those around the community, were not being tested for various reasons. And so we answered the call, and our team became mobile. I guess I should have mentioned prior that we were doing the drive up, but in addition to the drive up, we also had walk up options on site as well. So now we became mobile, and when we set up mobile at a local community site, our first site was in a housing community where we anticipated a large drive up, but ended up having a large walk up more so, and we were set up for both. We made sure that we had supplies and personnel to man each side. And in that first day at that housing community, we tested 134 people. So that was our largest day so far in all the weeks that we had been testing. No appointment was necessary. The goal still remains that we test as many people as possible. We're trying to identify high-risk hotspots in the county, as well as provide access for patients that otherwise would not have been able to get to the testing sites. Next slide, please. Next slide, thank you. So what are we doing now? We're in week 8, and we're looking ahead. Yesterday, we were in a predominantly Hispanic area actually in the Guatemalan Mayan Center had invited us out, and they alone had scheduled over 300 appointments that they organized. And so yesterday we ended up testing 362. So if I sound a little tired, that's why. We were out there for a long time, and it's hot here in South Florida. But that was our highest testing day so far. What we've learned with working with our community partners is that it really helps with the logistics. So some sites are better than others. So for instance, our site yesterday, as well as another site that we did a couple of weeks ago, at a free clinic here in the county, logistically, they're really great. Helps with the traffic control, identifying the individual patients that needed to be tested, getting them to the site, getting that out on social media, et cetera, et cetera. So really helpful in that capacity. In the beginning, I developed a form that was our intake form, and we're still using that form. We've adapted it over the weeks, and one of the requests was to add in that ethnicity section, to add in Maya, and the population that we were testing yesterday was predominantly Maya, Guatemalan Maya population. So, just being culturally appropriate, culturally aware, as well as utilizing a lot of their staff in order to build trust with the patients that are coming out, as well as to facilitate with communication. So in all of this, we're happy to be out there. We're happy to be in the communities. And I know that more other FQHCs in the area are starting to go to some of these underserved areas as well, too. So we've decided that although we won't say no necessarily, that we also need to have a presence here at home, meaning here on our main sites. So we're starting next week. After we get through this week, we have another testing day out in a rural area on Friday. But after that, starting next week, we're going to at least have one day a week where we're on site at Sound Care at our main site, in order so people can find us. And we can have that available for our established patients or anyone who's needing that to walk up. So again, the criteria, I've been the one really promoting, hey, let's keep the criteria pretty loose, because we've had so many asymptomatic patients, patients that say, well, yeah, maybe a month or two ago I had some symptoms, but I don't have anything, but then they're coming up positive again. When it comes to children, I am a pediatrician by training and practice, and I tell the families, if the child is fine, if you're just curious, I'm not testing the child because it's uncomfortable. But if there's some known connection, some known exposure, this child is sick, or we've gotten pediatricians who've sent their children to our sites with prescriptions saying, please test, then I'll test those children. And so I try to take it on a case-by-case basis at this time. I think as we move into other testing modalities that are less invasive, that'll be a little bit better access for, or better for the children. But I mean, I've tested all the way, yesterday I had a child who was 7 months old. So, but with met criteria that, warranted to be tested. So, we're taking that on a case by case basis. But, our goal also, and it has been from day one, other sites that are available, we let the community know, so people have access. And we have access to the IgG testing, and we just mainly use it for established patients or staff who are interested to know, but we've only done a handful of those. So overall, we've tested in these last 8 weeks, over 2,100 tests have been performed, approximately 120 positive, and doesn't sound like a large number, but I will say that the majority of that number has been in the Hispanic community. And I think, to my colleague's point from Rhode Island just now, you hit all the points that are likely why we're seeing such a high number there. And we've had a lot of asymptomatic carriers, and then, as I mentioned, with regards to the children. So we'll continue testing, and we're happy to be here, and I'm happy to take any questions offline later if there's any. Thank you, guys.
Great. Thank you very much. We appreciate that, Dr. Merritt. We appreciate everything that you and your staff are doing at Found Care. We do have one question I'd like to ask, and it's a part of a larger question. So if you have a moment, for Found Care, who does the testing for each site, and how do they handle the results communication and the wraparound services for positive patients?
So with regards to who does the testing, so I have a core team that I take out with me each time. And the reason for that being, I'm very particular about making sure we do great technique as well as keeping our staff and the patients safe. So I have trained some of my LPNs and nurses and even some of our MAs that I know can perform high quality, that I've trained myself and that I watch them. I allow them to do it. I also have internal medicine doc that comes out with us. He's new to our practice. So with regards to, he's not fully credentialed in all the plans, so he's kind of easy to be mobile at this time. And dentists. I've brought out our two dentists that we have at our main site to be out there testing with us. So they're the ones performing the test. As far as the follow-up with the results, even when we go to the community sites, I let them know that we handle all the results. All of that comes through my desk. I pull them all down and I make sure that I review all of the results. Any positives, I've been the one to deliver all of the positives. And for a specific reason, patients have a lot of questions. They have, concerns and want to know when they should be tested again and all these things. So I make sure that I'm handling that portion of it. And then with regards to the negatives, then we have several staff that have been trained throughout the organization that will help to deliver the negatives. And as we've gotten higher and higher numbers, I definitely need that help. So we've trained them, and our COO is the one who helps me coordinate with getting those results delivered. So did I answer all the questions? There was one more thing left.
Great. No, that was perfect. Thank you very much, Dr. Merritt. We appreciate everything you're doing.
I did have one more thing. Sorry.
Yep, go ahead. Yes.
Sorry.
Yes.
Just one last thing on that is that, one of the other pieces that we've done is train first responders. So at one of our larger sites, we had some of the EMS and fire come out, and I was training them and how to do the swab so that when they go out into the community, they're able to do it as well too. And I think that's how we expand capacity and access as well. So I think that's been helpful. But thank you.
Great. You are utilizing all of the healthcare workforce, and we appreciate that. So as we move on to our polling question number 3, we'll do this right on the webinar screen here. What is your health center's COVID positivity rate? 0 to 5%, 5 to 15%, 15 to 20%, or greater than 20%? So again, what is your health center's COVID positivity rates? 0 to 5, 5 to 15, 15 to 20, greater than 20. And so let's see those results there. Okay, it looks like the majority is 0 to 5% at 47% positive of those positivity rate is 0 to 5. And the next of those is the 5 to 15%. Greater than 20 is 14%. And then 15 to 20 is 11%. So great. Thank you very much for that third interactive poll. Next, we're going to turn it over to one of our colleagues within Quest Diagnostics, and we're going to hear from Dr. J, the Chief Medical Director at Quest. And he's going to talk to us about testing methods for COVID-19. So Dr. J, are you with us?
I'm here.
Great.
Can you hear me okay?
Perfectly.
All right. Well, thanks a lot. I'm here in Southern California. I'm our Chief Medical Officer at Quest, and have been on our front lines of developing testing and getting it out there. It's really great to hear hear you all on the front lines of healthcare during the crisis. So I'm going to take a spin through testing, PCR and serology, and then a few comments on what we're seeing in return to work, return to life. And then this is our timeline, that in early March, of course, we released the PCR testing. and rapidly got up to where we are now, which is having it available in 12 labs around the country, and also having a turnaround time that's acceptable, 2 to 3 days in every lab. And part of that is because the health systems have done a lot of great work, which we've seen today, in bringing up local testing services. So we now have a capacity to do about 55,000 tests a day through Quest. That's continuing to go up because we anticipate that there will be more testing, a lot more testing, particularly as various communities open up. I will talk about the self-collection space, and then, in the more recent timeline, of course, we have the antibody-based testing becoming available. And so I will definitely cover off on the accuracy issues there, and then some of the clinical utility discussion around IgG. So next page. So we have obviously multiple approaches to the PCR-based testing. I think the emphasis on the right here is really that we've done a lot of work with the FDA in particular to validate many different specimen types and the fluids as well, that I like to say the juice in the tube, but also the stability is now, we've shown that we can accept room temperature, refrigerated and frozen, and that has helped a lot actually with the logistics here. Let's go to the next page. Of course, the testing that is done with PCR needs to be adequately sensitive. The sensitivity threshold for the FDA is measured in limits of detection. And so we make sure in all cases that we have adequate sensitivity. And then, of course, their cross-reactivity studies are done. In general, these tests are highly specific to SARS-CoV-2. Next page. And I mentioned the specimen collection component. I would mention here, and I'm going to talk about the self-collection space, but in particular, we've had a lot of inquiries around saliva. And we are not currently doing PCR on saliva samples, although it is doable. We still have not seen data that is convincing that we don't lose sensitivity on a saliva sample as opposed to a nasopharyngeal or a mid-turbinate swab, for example. And in this context, we absolutely do not want to have false negatives. And we also have the self-collection kits, available. So access to testing is going to be, easier and easier over time. But this is kind of an overview of those samples that we do test. Next page. And I'll skip this as well. Next page, please. There is a place to go to on our website for our COVID, our providers, where we do inventory all of the approaches and the swabs and the conditions that we will accept. And it's quite a few, so it's worth, that we put it there so that folks can see what we accept. Next page. So, the CDC did, as mentioned, update their guidelines recently, and it was really a recognition that we've all seen that there is asymptomatic viral shedding, and there is viral shedding that can occur late in a disease, in an infectious course. And so it's really kind of an extension of the symptom-based strategy to say we need a longer time period before someone can come out of quarantine. But then you have, of course, the test-based strategy. And because of the prolonged viral shedding that we're seeing here, whether or not it's infectious is another matter that's being investigated. But a lot of employers, a lot of our providers that are doing return to work are testing people to confirm negativity on the PCR before coming back in to the workplace. Next page. So in the early days of this, the last month or so, Quest has done over 25% of the country's testing for PCR. And along the way, we worked with the providers and the health systems on this, the swab. getting the swabs to the right location. And I clearly we were in a pinch. We as a industry and a healthcare system were in a pinch on that. But part of the thing that we noticed also is that, this is, if you have a symptomatic individual who needs testing, what we don't want to do is bring them into a hospital necessarily, right? Which is why we ended up working as a healthcare system to create the drive-through setting, right? And in the drive-through setting, we've also been very involved with that and have done the testing for the Walmart drive-throughs, which picked up some of the FEMA testing around the country. Those are now available at like 20 to 25 sites around the country in Walmarts. And during that drive-through process, we began to validate the self-collection kits. And 3 or 4 weeks ago, we published, well, it's not published in peer review yet, but there was a release of information around the UHC, Gates Foundation, Everett Clinic, and Quest doing a study of 700 people with every which way to swab, including anterior nasal, mid-turbinate swabs, nasopharyngeal, and a tongue-based swab, and also comparing those between provider-collected and self-collected. And we actually, for the mid-turbinate and the anterior nares swabs, found that provider and self-collected, when done with the appropriate technique, were equivalent with respect to sensitivity. And so from that time, we have developed the self-collection program that involves either a self-collected mid-turbinate swab or a self-collected anterior nasal swab. And we validated it extensively in those Walmart parking lots, right? So we've heard earlier on this drive-through setting, I think others are moving this direction of it's sort of an ideal setting for an observed self-collection, right? Because it's, you're driving through, and as opposed to having all of the PPE required, if you can observe the individual doing that self-collection through the window, it's a better workflow significantly, and that's worked very well. But in addition, we have finalized the studies and are doing the last submission to the FDA for a home-based self-collection service without observation. And in that regard, the logistics are literally ship a kit to an individual address or hand it out with instructions and an instructional video. Self-collect either a mid-turbinate or an anterior nasal swab at home, ship at room temperature through FedEx drop boxes. Now, FedEx has drop boxes in every major metro area that can receive these samples. They are shipped at room temperature. They go 1 day to our laboratory. We do have a commitment from FedEx to say if there are not enough drop boxes in the right location, that they will, put those in metro areas that need them. And so we believe that this is going to be a very important approach, particularly for symptomatic people who should be sheltering at home anyway. And also, for those that are having trouble accessing it or at a lot of risk in coming out, to an event. The throughput for this, of course, can be scaled up massively, and the drive-throughs are important, and we continue to support that, but we feel this could scale to a much larger population more quickly. All of this requires a physician order and oversight. It's ideal if the physician group that is overseeing it has telemedicine capabilities to troubleshoot with the consumer. So next page. So I'm going to turn to the antibody testing, and I'm not going to lecture about antibodies and how they, what is an IgM and an IgG, but I'll make a few points here. We deliberately at Quest decided to not make available IgA and IgM in the early days. So we made this available a few weeks ago. We did IgG serology only. And the reason for that is we want to use our capacity on the IgG testing as opposed to the IgA and M at this time. So later on, we're going to make available the IgA and M. And we also feel that, the capacity is important to use on the more important of the, the IgG, but at the same time that there is, when the IgA and M become available, there's a lot of education that needs to occur to make sure that that's not used solely, alone as a diagnostic tool. And that people understand the difference, and most physicians do, that the RNA still needs to be done to ensure that viral shedding is not ongoing. So that this is what we're focused on is IgG. IgG response comes up pretty quickly in this infection. So by 7 days, most people begin to develop an IgG response, and by 14 days, almost everyone who will develop a response does. And I say it deliberately that way because there are a low number of people, maybe 5%, who do not develop a significant IgG response. So let's go to the next page, and I'm going to help us with this accuracy question. So I think one of the early speakers really kind of nailed it. I'm doing every day, I look on the FDA website to see how many applications there are for serology tests, and it's something like 170 now. Okay, and so when we got into this, of course, we take a look at what's available. We determine which of the kits or systems would be scalable in our laboratories. And then of those 170, we get down to 8 that have a significant data submission on file with the FDA. And among those, then we are very focused on identifying approaches with very high specificity. And very high specificity is, in fact, the most important issue around the use of IgG to determine if someone has been infected and or has potentially some level of immunity. And so we sort of put all of them through that. We ended up with 2, which is the Euroimmune and Abbott, and we are vetting others and bringing others on, but those 2 we then brought through our own in-lab validation studies to confirm that in our hands we had very high specificity. And so I'll show just quickly on the next page some of what we do there. Well, this is the testing itself. Again, IgG only, room temperature logistics. It's available actually at 22 laboratories around Quest. And the only reason that's important is we've scaled this up very quickly, and we do have 1 to 2 day turnaround time. It's a blood sample which is collected in a patient service center, one of our 2200, or a physician office or health system. Next page. So again, for both the Abbott and the Euroimmune, we're focused on specificity. Both of them are in the 99+% range for specificity. I wouldn't draw any conclusions on the difference between these numbers between Euroimmune and Abbott because they're not significantly different. We do a lot of cross-reactivity testing for both of these. You can see some of it on the left side. And in particular, on the next page, you'll see that we test against other infectious diseases for cross-reactivity. We also did a testing against common coronaviruses. And I will tell you, there is one virus out there that causes that does cross-react with most of the current SARS-CoV-2 serologies, and that is SARS-1 or SARS. And so, that's actually okay because SARS is currently not in circulation in the US, and also if it were, we would want to know about it. But otherwise, these are highly specific IgG assays for SARS-CoV-2. And even though they're very high specificity in the 99% plus range, they're still, as everyone knows on this call, if you apply a test like that in a population with very low prevalence of infection or very low seropositivity, you're going to have false positives. And so one of the things we're doing, and I'll show you in a subsequent slide actually, so let me hold that thought for a moment. So let's go to the next page. Yeah, so this is, of course, the big question. What does it mean? And it clearly, there's a lot of evidence that is leading us to believe that individuals who mount an IgG response that's highly specific to SARS-CoV-2 may have some level, or certainly as a class, people who have an IgG positive result are more protected, are significantly more protected from infection or bad outcomes from infection than those who are IgG negative. Also, it has not been shown yet in any of the 3.5 million infections around the world that there's been a definitive example of a reinfection with a virus after a primary infection with SARS-CoV-2. There was the interesting thing in South Korea. There were 78 people identified that had PCR negativity, had a positive result, then a negative, then a positive. But in that case, those were all then determined to be the same primary infection that was indolent or waxing and waning, as opposed to a reinfection. So all this, sort of lines of evidence here being put together, including the plasma taken from individuals who have recovered, having a neutralizing impact. All of this together, it puts us into a place to say there is absolutely meaning in a positive IgG serology, and there is some level of protection there. However, we really do need to understand what is the completeness of that immunity, what is the duration of that immunity, and what are the nuances relative to the level of the antibody, and do different antibodies vary in their predictive power for protective immunity. So I've sort of put it in a framework on the next slide to kind of say this is where we think SARS-CoV-2 sits, and that is not with lifelong immunity, but more in the way that SARS and MERS behaved, with a multi-year, 1 to 2 year immunity. However, we're still wondering, will there be mutations and changes in SARS-CoV-2? And this does still need to be validated that, in fact, there's prolonged, immunity conferred by IgG positivity. So next page. And the FDA did a couple weeks ago put out a guidance for healthcare professionals on the use of serology, and they hit pretty much the points that I mentioned. On the left, they really say, they do focus on highly specific tests, and then last week put out another thing on highly specific tests, and those that they have, blessed with holy water, identify people who may have been exposed and recovered. And then in the middle here, they were pretty aggressive with what they said that could mean, which is the person could donate plasma, but also that they may be able to resume work and other daily activities in society. But they also, on the right, are very clear to my earlier point, this should not be used, antibodies should not be used alone for a diagnostic purpose. And that's usually done, with a combination of IgG, IgA, and M. And we are not focused on that right now, as per my earlier, point. We're really focused on IgG, and then we'll make IgA and M available, soon. So next page. A lot going on in the scientific community trying to come to guidelines, also studies that are ongoing to understand seroprevalence around the country, the linkage, the dynamics between serology and PCR, the establishment of the protective linkage, the protective immunity linkage, and then finally implementation research on best practices for return to work. I want to mention here that I think one that would be most, important for this group is that Quest and LabCorp and others are working with the CDC to really rapidly get seroprevalence data in the communities around the country. And we have, of course, our own data, which is the results of ordered serology testing. However, that's a biased set, of course. At the same time, we are taking discards from chemistries done around the country, de-identifying and enabling the CDC to generate seroprevalence data. And so from this, we have a map, that emerging where we can really look at what is the rate of infection in any one community, not infection, but IgG positivity. The reason I say this is that, let me go to the next slide and explain why this is so important. In a scenario where we're thinking about returning physicians into a hospital or returning workers into a plant working on meat packing, or developing, producing respirators, we are very clear about the role of PCR, which is to be used in a way to prevent viral shedding in the workplace, right? And make that available to people who are symptomatic clearly or have had a high risk contact, or perhaps, and we're doing this now in certain of our labs, a top-down program that says we're offering it to everyone, including the asymptomatic folks. But if you then layer serology onto this, and you think about it, the serology becomes much more valuable in a setting where you have a high seroprevalence. So I'll give you an example. I'm from Tulsa, Oklahoma. The seroprevalence right now is less than 1%. But at the same time, our headquarters is in northern New Jersey. There are counties there now where it looks like 40 to 50% seropositivity. So it's a very, very different context. If I'm working in Tulsa, the IgG serology is not going to be very useful. And in fact, I'll generate a lot of false positives by using it in that environment. If I use an IgG serology in New York and in northern New Jersey, and I have 40% seropositivity, I'm going to have a high yield. I'm going to identify a lot of people who have an IgG positive result, and once I know that they're not shedding virus, they're very unlikely to bring it into the workplace. And I could start to potentially create a workplace that has shield immunity, where 60% of people in that place are IgG positive. So a lot of, I think that's just it's way too much to go into more detail here, but certainly the role of IgG is highly dependent on the prevalence of positivity in any one community. So I'll go to the next page to come close to wrapping. So this doesn't even really do justice to it. You'll see in the upper right there in the New York quadrant, you see 26% on average seropositivity from our own data. And again, that's biased, but if I then drill in by county, I've got a county that has a 60% seropositivity rate. And then if I click over to, Tulsa, again, I'm at, 0.4%, a very, very different context with respect to return to work programs. So next page. Just want to make sure to stay within time here. So the last part is that all of, a whole bunch of what I just covered is available on the Quest website. There's a COVID page for healthcare providers, and we've got all the details around the acceptable specimens. The turnaround time is published for both the PCR and serology there, and almost all the information I presented today. Also, my presentation is there, I think, as an attachment to the program or the go-to meeting. So happy to take questions at the end or along the way. And thank you for letting me sort of share this with you.
Great. Thank you very much, Dr. J. This was very informative information. I know many of the people do have a lot of questions. We've put them in the chat, and we'll get those to you later. We won't be able to answer them in real time in the webinar, but thank you very much. And yes, all of today's presentations, including Dr. J's, can be downloaded right now on the right-hand side of the go-to webinar. There's a link for handouts. There's a couple of handouts there, and Dr. J's are there within the entire slide deck from today's presentation. So again, thank you very much, Dr. J. We really, really appreciate that information.
Thank you. Appreciate it.
So next, let's turn to our national colleagues at the National Association of Community Health Centers. And our friend, Kathy McNamara, is going to talk to us a little bit about the national perspective. So Kathy, are you here?
I am. Can you hear me?
Perfectly. Thanks, Kathy.
All right. Thanks, Tim and Fred and Alex. And to be honest, I am just really humbled and so proud of all this great work by health centers. It reminds me that it's sort of a back to the future, right? Back to the 60s when we're doing closing the healthcare gap with innovation. And the testing that's occurring right now is actually exactly what health centers do really, really well, regardless of other factors going on. What I really want today, what I'd like to bring up is NAC, again, is working really, really hard behind the scenes, aligning kind of federal policy, legislative policy, and reimbursement policy to keep health centers whole during this incredibly tough crisis for those on the front lines. In addition, we're working very closely with Jim McRae and his team, CDC, health departments, and the informatics infrastructure at CDC to align our work to best serve health centers at point of care. Today, what I'd like to talk about is really, next slide, please, just 3 high-level things. I will keep in time. I think you know best what works for you. The complexity of testing defined in this current environment, strategies that health centers are currently using beyond what you've already mentioned, and some models. So next slide, please. This is really the ecosystem of testing. Like you, I deal with testing day in and day out from everyone nationally, and everybody thinks it's a swab or point of care test. But it's really much more complex and needs to be managed over time and across systems of care. And so one of the conversations we are really having with the Bureau and CDC is like, what are the assumptions we're working on here? And the assumptions include all health centers are expected to do some level of testing. Second, that they're expected to use CDC guidelines. What about that contact tracing that everybody's talking about as well? That is at the national level, discussions around that is very much a public health. But as we know with HIV, there are many health centers that do case reporting and other things very well. The other important discussion point, is this a short-term strategy or is this a long-term strategy? And given the past presentations, particularly the ones about the labs, it is really going to health centers are going to have to address the infrastructure on short and long-term strategies. Next slide, please. So testing is really complex. And again, I applaud those presentations today, that they not only have the capacity, the insight, the workforce, but they also are willing to take the risk. And so not all health centers are in that space. So what we're encouraging health centers to do, some have furloughed people, some don't have the right staffing models, that they align capacity with the risks they're willing to take and able to take around testing. And this actually comes up to be about 4 models, nothing new to anyone on this call, is one, that health centers test their symptomatic patients just like they would test them for any disease. The second is health centers are encouraging testing with their patients, but they refer them to a remote site. Given the changes in the healthcare system over the last couple of weeks, telehealth, some health centers are encouraging testing through their provider and care teams because they're symptomatic. And so it's a telehealth model. And the other one, the other telehealth model, is referring to a remote site. So these things are really important because at the end of the day, I just encourage health centers to be collecting that data and really looking at where their costs are, because this will inform some of the decisions that you're going to have to make down the road, aligning capacity and risk. Next slide, please. And so what are the current testing models? We heard 3 excellent ones today, just really unparalleled. But in addition, some health centers that are more rural, they serve subpopulations. There's about 3 other models beyond what was listed here. One is that the health centers are testing any symptomatic patients within their local community at their health center. And that includes not only those defined by a patient visit or who their patients are, but also their family members and community members. The next thing is like similar to the three that were noted here today, where health centers are actually the lead in setting up remote sites. And they're doing it specifically many for subpopulations where health centers are actually the trusted broker in the community, such as farm workers, such as homeless, maybe some LGBT sites, where those trusted relationships are really important. So health centers are really taking the lead in those subpopulations. And the last model is really where the community and the state has come together, where health center staff, hospital staff, public health staff are contributing to remote testing sites where they have really cycled through different staff forces. So example, the hospital is doing all the lab. However, the hospital workers are traded off by health center testing either during the week or on the weekends. And so they have a rotating staff to cover those remote sites, with the hospital owning all the testing responsibility. But again, if we went back to that ecosystem and many of the points that were brought up today, who is contacting those patients with the results? Are they being linked to care, and are they linked to care over time? And so I just want to keep challenging us to keep it as a patient-centric, provider-centric care model. And lastly, next slide, please. So a very excellent resource for those who have not seen it. AMA has put out something with the CPT codes and reimbursement models, and I've added that link there. Next slide, please. And lastly, tomorrow, we will be having a webinar also on testing, looking at our CDC Bureau partners, as 600 million will be released within the next 1 to 2 weeks from the Bureau of Primary Health Care, supporting the implementation of testing in health centers. Next slide, please. And with that, if anybody has any further questions or I can be of help to anyone, I just really want to feel free to contact me. It's a 24/7 day right now, and we appreciate it. And yes, celebrate the Year of the Nurse. They're doing great work in health centers, and particularly in the COVID-19 epidemic. So thank you all for the opportunity, and I'll turn it back to you, Tim.
Thank you very much, Catherine. We appreciate those words, and we appreciate everything that NAC does for the health centers across the country. And please join NAC's webinar tomorrow. I hear there might be some special guest speakers on tomorrow's webinar. So our last speaker comes to us from the public health sector. And since I was unable to get Dr. Anthony Fauci, we went for the second best speaker that we could get, and that is Massimo. So Massimo, can you tell us a little bit about what's going on in the public health sector?
Sure. And I know you can't see me, but I actually look a little bit like Anthony Fauci, although I'm obviously a poor stand-in. It's my Italian background that aligns us there. In any case, thank you for the invite, and really thank you for the opportunity to speak to you. And we have really just spent the last hour or so learning about all the many efforts that your settings and labs are carrying out in the context of COVID-19 testing. So perhaps I'm really just left with the opportunity to summarize some of these components of testing and reporting to public health that informs all of us, and perhaps a very brief situational update. But really, perhaps also an opportunity. I'm happy to distribute to the group additional epi-analyses and sort of resources that the Chicago Department of Public Health compiles, and also perhaps a plug for work that specifically faces health centers and future opportunities to come together. I'll refer to towards the end. So next slide, please. so here is a very high level sort of national update. These are the national map that reports cases of death and deaths in the United States. And sort of here is the current heat map identifying the number of cases reported by each state, with over 20 states reporting more than 10,000 cases, and most states having documented widespread transmission. Next slide. And so here is an epic curve of sort of showing the new cases of COVID-19 reporting by day in the US since the beginning of the outbreak, which is hovering still around 30,000 cases nationally, which some sort of encouraging signals, so perhaps a flattening in the last couple of weeks or so. In Chicago, we're still around kind of documenting around 800 cases a day, and with now cumulatively over 25,000 cases and 1,000 deaths to date. And in particular, when we do analyses and sort of stratify by race and ethnicity, we see Latinx and Black non-Latinx population really overrepresented in both the case rate as well as more severe outcomes. Next slide, please. And so here is and sort of another plug for reporting and sort of describing what it is that we see. It really sort of begs the question of how much of the iceberg are we really seeing? While the most severe cases and deaths are likely to be identified initially and most reliably, the overall proportion of cases really relies both on the volume of testing performed, as well, of course, of expanding testing to less sort of severe presentation of the disease, and the complete reporting of those identified cases. Next slide, please. Next slide, please. And so regarding volume of tests performed, you could sort of observe, previous slide, apologies. Observe sort of the red line that represents the U.S. testing rate, which has been increasing over time, although challenges to sort of adequate access to testing sort of remains as sort of the complicated system that testing requires. And here, data sources are quite variable and not directly comparable, but the graphic sort of represents the number of tests performed per 1,000 population. And so this is really sort of correlated with the proportion of the iceberg we see. And it's sort of the proportional to the number of tests performed, as well as to the many measures that we aim to compile as we describe the pandemic. And so the positivity rate, the cumulative incidence, the case rate. So it's, again, not only performing a high volume of tests representative of the population in need of testing, and also kind of the being able to see those tests in the system and be informed by those. Next slide, please. And so we couldn't agree more with all the great work that it was outlined in prior presentation. We really recognize the critical importance of health centers for COVID-19 testing. And so it really, this lane is featured prominently in the city strategies to meet this updated guidance that recommends clinical testing for all symptomatic individuals, and for whom it really is important to do testing in a clinical context to ensure that the patients can then be appropriately managed. And so, again, with Chicago seeing sort of this significant racial ethnic disparities in disease burden, with concentrations on the south and west side of the city, here too is where highlights the opportunity for health centers to appropriately sort of address the needs of those populations. And so the health department, so certainly at the city level, but really working with partners at the state and leveraging federal assets that are now being distributed around swabs and collection media, as well as PPE, et cetera, to really sort of appropriately support your settings. So this is a recognized sort of area of opportunity and certainly an area of growth. and perhaps another plug for, forecasting outreach in Chicago from our department to settings to both appreciate what support can mitigate your needs and probably allocate resources to those. Next slide. Okay, so here, back to really my presentation comes at the end of a full agenda focused on the topic, but perhaps an opportunity to summarize the methods, highlight challenges and opportunities to ensure that testing that is performed informs sort of the clinical approaches and the public health response. And so here are the two buckets we've been talking about in terms of the lanes of testing, viral tests representing the current molecular available PCR test-based methods, and as well as a plug for that which we read in the news a fair amount lately, which is the forecast of antigen testing, and then antibody testing sort of as a indicator of previous infection, past infection. Next slide. In terms of the description of respiratory specimens collected to diagnose current infection, we're really talking about molecular tests that identify SARS-CoV-2 virus that causes COVID-19. And so some of these tests may be point of care, some they were highlighted like the Abbott Clear ID Now, but most of them sort of requiring the send out, but really seeing much improvement as availability becomes broader in the turnaround time for these tests, able to then inform both clinicians and certainly public health approaches. And so here is a reflection, and I sort of appreciate sort of shifting guidance over time presents challenges to us all. But here is sort of reflected from national guidance that kind of removes the preference for nasopharyngeal swabs to sort of articulate a variety of specimens that may be appropriate for collection for molecular testing. And so beyond the nasopharyngeal swabs, they're really and oropharyngeal, which are to be collected by healthcare professionals, sort of introducing the deep nasal, the mid-terminal nasal swab, as well as anterior swabs, as opportunities where specimens can be collected with supervision of healthcare professionals, but perhaps self-collected by individuals. And then, of course, nasopharyngeal and nasal wash aspirates are also appropriate specimen types. Next slide. And now, if we move to the safety of collecting those swabs, the recommendations for infection prevention and personal protective equipment really depend on the type of specimen collected. And so they broadly include sort of performing the specimen collection in a normal examination room with the door closed, and then, of course, doing so outdoors in the drive-through scenarios sort of mitigate that challenge in a different way. And then sort of wearing respirators, eye protection, gloves, and gowns, but really recognizing that given the shortage, N95 type respirators should really be prioritized for other procedures that are higher risk of producing infectious aerosols. And really what is needed here is a surgical mask with a face shield. And sort of always valuable to limit the number of healthcare personnel and certain visitors during that specimen collection. But it's sourced, again, an opportunity here to highlight how the collection of the nasal swab specimens, that it's less technically complex, can really reduce the risk of spread to infection to healthcare providers by both reducing the duration of the procedure and allowing the patient to self-collect, sort of this opportunity for the providers to be 6 feet away. But of course, in healthcare settings, for healthcare providers to don face masks for source control for general guidance. Next slide. Yeah, so this was highlighted before how, this is an early study, but kind of highlighted the predictive value of collecting specimens other than nasopharyngeal swabs. This is a report focused on whether the virus can be detected in specimens other than nasopharyngeal, with these over 1,000 specimens collected from 205 symptomatic patients. And just to highlight sort of how the nasal swab sort of was well represented, and in fact, the cycle threshold, or sort of an indicator of the higher viral load, was actually higher in that type of specimen. All that to say that it's certainly, from some of the data that was presented even today, and then hearing from colleagues in both clinical and public health laboratories, it seems to be a well-validated alternative specimen collection type. Next slide. So here's just a reminder for all of us of how this all works in sort of collecting an appropriate specimen to then extract RNA to amplify and then tag that to an observable fluorophore and then detect from there. And it really, this is all sort of, it makes us appreciate the chain from beginning to end, how results are all kind of all the way connected from the quality of the specimen to the extraction, amplification, and detection component. And so while, of course, detection of the virus RNA really indicates that the virus is present in the specimen collected, if negative, this only indicates that the individual has no RNA present in that specimen at detectable levels, but it certainly doesn't rule out past infection or the possibility of infection for future exposures. And certainly, sort of additionally, the implication that the quality of the initial specimen has in the eventual outcome of detection. Next slide. So there's a number of reverse transcription polymerase chain reaction kits that have been designed to detect SARS-CoV-2, and it really sort of focus on different targets in the open reading frame and e-gene of the envelope and the nucleocapsid protein targets. All of this to say there are many, many ways to read the letters that get us to the signal, and an appreciation of how complex so the landscape of the instrument involved in both the extraction and the amplification, reagents, primer, probes, that are sort of distributed across all of our labs in our system, and sort of speak to that challenge and this time of high demand and supply limited sort of landscape of trying to ramp up high volume of testing in a very short period of time. So next slide. And really, here is again appreciating one of the speakers kind of highlighting this, how the challenging criteria for who is to get tested really presents some challenges of communication and education, certainly for both providers and patients alike. But really overall, identifying the population for testing require really balancing the testing availability with the testing priority. And so during the early phases of the response, with limited laboratory capacity, COVID-19 testing was really prioritized to optimize care of hospitalized patients, identify those at high risk of complications from infection. And as laboratory capacity to diagnose the disease has increased, to support testing for many in outpatient settings who have symptoms suggestive of COVID-19. And so certainly sort of many jurisdictions are represented on the call, and there's much guidance provided by each of the local settings. But in Chicago and Illinois, certainly providers are encouraged to obtain specimens for molecular testing of all patients seeking care or are symptomatic, even those with milder symptoms. And I guess on the right-hand side, recognizing that when resources are limited, sort of CDC provides this updated framework to prioritize sort of the high priority were sort of highlighted as before, and then inserting this additional lane of kind of defined by public health officials of individuals for whom who are disproportionately affected by the infection, as well as disproportionately represented in the poor outcome. Next slide, please. And so of fundamental importance is the part you all play as providers and laboratorians reporting to public health for individuals who test positive for COVID-19. So those data contribute to the cascade of data sharing that sort of allows for informed dissemination of guidance for public health response. And particularly in sort of the context of upcoming relaxing of isolation stay-at-home orders, complete and prompt reporting will be fundamental for the case investigation, contact identification, and follow-up for the purpose of monitoring for symptoms and testing for signs of infection. So the figure on the left is a significant illustration of how SARS-CoV-2 was spread to communities beyond household contact, healthcare workers, and residential facilities. This is published in MMWR, kind of reflecting investigation between February and March of this year, where a large family cluster of individuals with confirmed COVID-19 disease and their close contacts are described. And the study illustrates sort of 16 cases of confirmed or probable disease, including 3 deaths, all of which are believed to originate from one single individual that spread to through the participation in 2 different gatherings. And so the virus caused illness beyond the original infected contact through additional activities, including providing care for one of the symptomatic individuals, household exposures, hospital visits, and attending service. And so the chart here illustrates the movement of infection through the 16 individuals, sort of indicating the order in which each individual was infected. But next slide. And here is going back through a little bit of a summary of methods, a review of serologic approaches, although that was very perhaps and more in-depth provided by also by a prior presentation. So next slide. Sort of, again, a reminder, next slide, that antibody testers are really looking for presence of antibody, which is sort of identified as the result of infection and sort of lagging in terms of time in presenting in the specimen. And so in terms of the lanes of antibody tests, here are some pictures to take us through the sort of the framework around this rapid antibody test, this rapid diagnostics that rely on this lateral flow assays, returning qualitative results sort of rapidly, the more traditional laboratory-based enzyme-linked immunoabsorbent assays and variations thereof that may turn both qualitative and quantitative results, and then on the far right, sort of the specific neutralization assays that provide quantitative information on the ability of patients' antibodies to confer protective immunity potentially. And so next slide. Really, serologic tests do not play a role in the diagnosis of acute infections in symptomatic individuals, since again, the response may take sort of weeks to be detectable. Negative serology would therefore not exclude SARS-CoV infection in a patient with recent exposure to the virus, and certainly the challenges with cross-reactivity to other common coronavirus. So all this to say that much is to be defined in this lane, and also a lot of work is occurring in this lane, and we're really sort of craving that much of the data that's sort of being generated and sort of really providing information how to best deploy this additionally valuable component that, although perhaps not suited for diagnosis of acute infection, can provide a lot of information to the response overall. And in fact, CDC, HHS, BARDA sort of have forecasted an evaluation that's to be forthcoming on serologic methods. And to date, there are several that have received EUA approval, and certainly many are to market, some of which were described. And all this to say that sort of an area of a lot of growth, both on the technical side, but also importantly on the interpretation and the public health actions that it informs. Next slide. And so here is a sort of not a complete list by any means, but perhaps a list of potential utility of serologic testing, which includes sort of the detection of PCR negative cases for those who may present late with low viral load below the detection limit of RT-PCR assays, perhaps to identifying covalescent plasma donors, certainly for epidemiologic studies of disease prevalence in communities, and the important work kind of associated with the vaccine response as more of serologic signals and implications on immunities are better defined. And also sort of here is to reflect how sort of CDC is beginning deploying these methods in conducting large-scale geographic surveys, community-level surveys, as well as smaller-scale focused on specific populations. So again, all this to reflect that this sort of remains an area where we'll continue to learn a lot from both the practices and your labs and sort of nationally, seeing how these are deployed and how we can be informed by them. And then here is sort of this next lane. I sort of, even in the priority for COVID-19 testing, it sort of reflects this other lane of antigen testing, as well as sort of the definition for case reporting includes this element as well. And so it's sort of signaling that although antibodies may not be suitable for diagnosing of active COVID-19 infections, antigens are likely detectable from the onset of symptoms. And what's more, sort of, extrapolating from technologies that apply to other diagnoses of other diseases, this is certainly an area of opportunity once a kind of robust point of view test exists, or it's validated to be deployed for sort of almost this door-to-door type of framework as contact tracing is deployed, and perhaps provide if nothing else, a first opportunity to screen and predict those who may require additional testing. But this is really nothing more to me than reflect sort of a next frontier, given that, again, much is to come in this lane. Although certainly there's been plenty of work in characterizing sort of both the structural proteins, the spike proteins, and non-structural proteins that are sort of the target for these type of technologies, and certainly aligned with the other that which we're all waiting for, which is the down the line vaccine development and deployment. Next slide. Yeah, so I think that is all I have. Oh, I wanted to represent sort of the resources for health centers and sort of work of others here at the health department, and also a plug for upcoming outreach, perhaps to this group, for some Chicago-specific information. And then I do have a next slide, to really highlight sort of the health department is really trying to ensure and support opportunities for reporting of COVID-19 testing from health care centers. And recognizing that, particularly for those centers that are connected to our large commercial reference labs, there's really robust robust ELR, so electronic laboratory result reporting. But it's certainly those data are, from a specimen perspective, the rich information of demographics and clinical and exposure information really comes from the clinical settings. And so certainly this comes with an order, but it's really sort of a commitment for the health, the health system overall, really, to identifying informatics solutions for enriching that reporting beyond for more complete and more robust data that allows us to describe what we see and intervene appropriately. So I think that's all I have, and I guess perhaps questions offline. But thank you again. And yes, even serology is reportable. So again, I represent public health, and the best way to assist is to be informed. So this starts with all of us. Thank you.
Great. Thank you so much, Massimo. That was some very valuable and informative information, and we really, really respect the public health work that you're doing in this department, in this area. So I want to thank everyone for joining today's webinar. On the screen here, you can see some of our resources. They're on both Health Choice Network and Alliance Chicago's webpage. You can use the scan codes here, or if you download today's slide deck from the handout section on the GoToWebinar, you can go ahead and do that. But most importantly, we want to thank all of the healthcare heroes. Here's a list of the names of healthcare leaders and heroes working within the Community Health Center movement to help fight COVID-19. And once again, thank you for joining our webinar. My name is Tim Long, and on behalf of Health Choice Network and Alliance Chicago, next week's webinar will be a little bit later. We'll probably start at 1:30 Eastern. We want to make sure that our friends and colleagues in Hawaii and the West Coast are able to join us. So once again, thank you on behalf of Health Choice Network and Alliance Chicago. I hope everyone has a fantastic day, and please stay healthy and safe. Smile. Goodbye.